Health in the College of Nursing, and this conference is provided by a Health Resources and Services Administration grant, and the name of our grant is Helping Our Healthy Moms and Babies. And so with that grant, we provide stipends to nurse practitioner students who commit to work in a rural area or in an underserved community. We have family nurse practitioner students, psychiatric mental health nurse practitioner students, and nurse midwifery students. And so this afternoon, we have a great panel of speakers, and Dr. Loyd will proceed with our keynote. First, I want to introduce the moderator, which is Dr. Kate Fuquay, and I have the opportunity of working with her quite a bit with the grant and in various projects. She is a professor of nursing and the concentration coordinator for the nurse midwifery program at UTHSC. She is also a practicing midwife at Regional One Health, so if you need well woman care or pregnancy care, sign up for her clinic. And Dr. Kate has also done a school-based health clinic in Jackson, Mississippi that was a really neat primary and preventative care clinic. So I'll turn it over to Kate.
Hello and welcome. We're glad that you joined us today. I have the honor of introducing our panel of speakers today. I'm going to give you the Cliff Note version of their accomplishments, so I encourage you to go to our site on CE Now to see their full CVs so that you know exactly how impressive our speakers are and how lucky we are to have them today. Our first speaker today and the moderator, keynote speaker, is Dr. Stephen Loyd. Dr. Loyd is a graduate of Killen College of Medicine at East Tennessee State University. He completed his medical residency in internal medicine at the same institution, and he has served as the chief of medicine at the Mountain Home Veterans Medical Center in Johnson City, Tennessee. Recently, he was the medical director and assistant commissioner, or as we call him, the opioid czar, for substance abuse services for the Tennessee Department of Mental Health and Substance Abuse Services. For the last 10 years, he's focused on addiction medicine with an interest in the opioid-dependent pregnant patient. He's currently the medical director for the Cedar Recovery Center, Journey Pure at the River, and New Hope Treatment Center. Dr. Loyd has been in recovery from addiction to opioids and benzodiazepines since July the 8th, 2004. Our second panelist is Dr. Monty Burks, and if you've not heard him speak, you'll be in for a treat this afternoon with all of our panelists. But Dr. Burks is the director of the faith-based initiatives for the Tennessee Department of Mental Health and Substance Abuse Services, where his role is engaging and connecting Tennessee's faith-based communities to the behavioral health care system. His goal is to expand addiction and mental health support services across our state. He also oversees the Tennessee Lifeline Peer Project. In this project, it's a state program aimed at reducing the stigma that's associated with people who suffer from addiction. Another branch is the Tennessee Faith-Based Community Coordinators, and they seek to help congregations build their capacity to combat addiction and mental health issues in their respective communities. And the third arm of this is the Tennessee Collegiate Recovery Initiative that's geared at helping college students and administration become recovery allies. It truly takes a village. Pastor Diane Young is with us today. She is a wife, mother, grandmother, sister, preacher, and teacher. She facilitates support groups, ministerial training classes, and individual and marriage counseling at the Healing Centers Counseling Center. She is a pastor at the Healing Center Full Gospel Baptist Church in Memphis, Tennessee, where she is proficient in organizing, unifying, and networking. She attended the University of Memphis and Carolina University, where she received her BA, and she also attended Light University. She has an honorary doctorate from St. Thomas Christian College in Jacksonville, Florida. She is a certified wellness inventory coach and a certified marriage and family counselor. And I thought the most interesting thing is that for 27 years, she and her husband, Dr. William Young, have co-hosted the oldest Christian radio talk show. It's on Sunday mornings in the greater Memphis area, and it's called On the Road to Healing. Amy Wyrick, I hope that I have said your name correctly. Amy earned her bachelor's degree in communications from the University of Tennessee at Martin and her law degree from the University of Memphis Cecil C. Humphreys School of Law. She is the first woman to serve as the district attorney in Shelby County. Now, her CV is long with all of the programs that she is involved in. She helped create the multi-agency gang unit. She helped with an initiative called Operation Comeback, which is aimed at deterring high-risk offenders by getting them on the path to success. She created the first community justice program where they look at restorative justice approach with the aim of making the victim whole. They address the needs of the offender, participant, and they give the community a larger role in the criminal justice process. She's not only pushed for harsher punishments for violent offenders, but has also embraced innovative ways to prevent crime from happening in the first place. Her office sponsors the annual Do the Right Thing anti-violence essay contest for Shelby County school students, and she created Lives Worth Saving, a prostitution diversion program with Calvary Episcopal Church and nonprofit organizations. So please welcome all of our guest speakers for this afternoon.
And without further ado, here's Dr. Stephen Loyd.
Well, thank you. Good afternoon. Had to make sure. Thank you guys for coming. Anytime I do these things or I get invited, I always get scared nobody's going to show up. And so I'm certainly grateful to see you all. We're going to tackle a topic this morning, basically that got me into addiction medicine. And when I was coming through training, and in East Tennessee, I'm an East Tennessee guy. I'm from Jonesboro, Tennessee, a very northeast corner of the state. I'm closer to Canada than I am Shelby County, just so you know. So matter of fact, I told them when I got here, when I first got the job with the state and was responsible for the whole state, I wanted to learn it. And one of the first places in West Tennessee I went to was Dyersburg, which is just on the other end of nowhere. It was a long way away. And I like Dyersburg, but I had never seen cotton before. And so I had a suit on. I don't wear a suit anymore because I have a choice. So I got out and was feeling the cotton, and the farmer came by. I thought I'd lost my mind. But I've been to West Tennessee a lot, and now, many years later, so many great people. You're going to hear Diane Young in a little while. I'll finally get to say hello to you. Just awesome people that I've met that care about other folks. And so, but coming through training, I was in East Tennessee in medical school. Your third year, you rotate through, right, all the specialties. And then, in your fourth year, you rank them, as to what you want to do. And at the very bottom of my list, the bottom two things, no way in hell I'm doing either one of them, psychiatry and OB-GYN. I wanted no part of the birthing process. I told people the placenta used to hit me in the back of the head. I couldn't wait to get out of the room, right? And now, years later, the passion in my life is the opioid addicted pregnant lady. It's what gets me up in the morning. I don't have any hobbies. My son's over here. He'll tell you, I don't hunt, I don't fish, I don't play golf, I don't do any of that. I do this. And it's because of falling in love with treating a patient population that I never dreamed that I would care about. I never dreamed I would understand anything at all about contraception in any form. I didn't care. And now those things, basically are the direction of my life. So let me tell you how I got involved in it. First of all, addiction medicine. I'm an internal medicine physician by training. I worked 15 years as a hospitalist in Northeast Tennessee. I was in academic medicine. I've been the chief of medicine. I've ran residency programs. I worked in the VA system. Taught in all levels of medical school. I taught in nursing school at East Tennessee State in their Doctor of Nurse Practitioner program for several years. Addiction medicine was not on my radar until it happened to me. Until I became addicted myself. I didn't understand anything about it. I know what your all's training is. My guess is you understand equally about what I did, which is very little to nothing. I felt like the people who got addicted made that choice, and so that was their lot in life, and they would have to suffer the consequences, and it was pretty much a moral failure. But it was a different story when it happened to me. So I was on my way home from work one day as chief resident. I was responsible at the time for about 130 inpatients at a VA medical center, and I thought my life was pretty difficult. This is in the early 2000s. Didn't like my wife very much, thought my kids were pretty poorly behaved, and I had a lot of job stressors, and I'm getting ready to come out of residency into a job, so my name's going to be on the bottom line. And I pulled up to a red light in Johnson City where I was living, and right across the street was Colonel Steve's liquor store. And I flipped open the glove compartment of my truck, and I had some Norcos in there from a dental visit I'd had months before. A dentist did some stuff to me, gave me a handful of samples. I threw them in the glove compartment of my truck. Didn't even think another thing about it, never used one of them. And I'm sitting there looking at those Norcos, and I said, my patients take these things all the time. I actually had that conscious thought. And I broke one of them in half, 2.5 milligrams of hydrocodone. And I threw it in my mouth. By the time I got home to Karen and the kids, by the way, I'm still married to her, and the problem wasn't her, surprise, the problem was me. But at any rate, I got home about 10 minutes later. Suddenly my wife is not as bad as I think she is. My kids are better behaved. My job stressors are much better than I thought they were. What had changed in that 10-minute drive? Nothing, right? Nothing had changed. What I didn't know is I didn't know the area of my brain that detects pain. You all know this. I'm sorry, Megan, you're on the front, so you're it, all right? So I take a hammer and I smack Megan on the toe, all right? It's going to be right, I hit her in the toe, that's where the pain is. But if her brain can't sense that pain, it won't hurt, right? So if I could cut the connection, she would never feel it. Actually, you can, hit somebody who's been paralyzed on the toe with a hammer, they won't feel it. And so here's what I learned, is that the area of our brain that detects pain doesn't separate physical from emotional pain. It's the same place. So the narcotic that eased my pain from getting whacked on the toe with a hammer also eased the emotional pain that I'm carrying around with me from physical and sexual abuse as a child, from behavioral stuff that I'd battled for years, anxiety, depression, sleep issues, and suddenly my life is a lot better, right? How many people get trapped in addiction this way? They have a sports injury, or they have a knee injury, and they get on pain medication, and the pain goes away, but the pills never do. And a lot of times it's because of this underlying things that nobody wants to talk about. Megan comes in to see me, she's having a hard time sleeping, and I'm going to age you a little, Megan. Megan's now a middle-aged female. Okay, she comes in to see me, she's having a hard time sleeping. What's the easiest thing for me to do as a doctor? Ambien 10 milligrams, number 31 POQHS, I'll see you in 6 months. All right, I can do that in 2 minutes. What's the hard thing for me to do? Find out why she's having trouble sleeping. What's going on in your life? Okay, middle-aged woman. Husband doesn't look at me like he used to. My kids are grown, don't need me. Whatever it is. Those are hard things. All right, the easy thing to do is write the medication and she goes and gets out of your way. We do this stuff all the time. We do it in medicine all the time. A lot of what we treat is underlying behavioral, and that's what I learned. So I wound up getting help in 2004. I came to Vanderbilt. I spent 5.5 days in a detox unit. And then I went to a place called the Center for Professional Excellence, CPE. They only treat doctors, lawyers, and airline pilots. And a guy named Chip Dodd saved my life. I love Chip to this day. But he changed my life. But he not only changed my life in addiction, my son's sitting over there, the younger kid that needs a haircut. He changed Heath's life. Heath was 9 years old when I got into recovery. He's never seen me do any of that stuff. Think about how different his life is now compared to what it would have been had he seen me continue on that path, because I wouldn't have made it. Because within 3 years of that day I told you about at Colonel Steve's liquor store, I was using 500 milligrams of OxyContin a day. So how much is 500 milligrams of OxyContin a day? That's 100 Vicodin. Not 100 milligrams, 100 pills. Vicodin's 5 milligrams. 500 milligrams is 100 pills per day. I was using it every day. And I wasn't living underneath the bridge. I was living in a house in a neighborhood that I never dreamed I'd live in when I was a little boy. None of that stuff, right? I'm doing that every day, and I'm seeing your relatives in the ICU. I'm a hospitalist. I'm an intensivist. I work on a medical step-down unit. I work in the ICU. I'm seeing your family members every single day while I'm doing this. Pretty soon, I couldn't go to sleep. When you can't go to sleep, what does somebody give you? Benzos. So I wound up addicted to benzodiazepines as well, Xanax. I was taking about 2 milligrams of Xanax anywhere between 3 and 4 times a day, every day. Okay, in the 4 years that I did that, the graduating students at our medical school voted me the best teacher in internal medicine 3 years. And the last year that I used, they voted me the best teacher in the whole school. Okay, you can be functioning and it's going on. And I'm looking around this room right now, just eyeballing it, guessing. There's 5 of you in here that have a problem with substances. I can't see you, don't worry. But there's 5 of you in here. There's some of you that it's been going on a while, others are just getting started, right? But you're not going to tell anybody because of the shame and stigma associated with it. So I got help, it changed my life, and I remember sitting in treatment. I'd been there for about 6 weeks, I'd been through the withdrawals, I'd been through all that stuff, and I remember thinking, I still have a job. The president of my university, Dr. Paul Stanton, the dean of my med school, Dr. Ron Franks, didn't fire me. Matter of fact, they paid me every day I was gone. I never missed a paycheck. How many people do you all know that got to go to treatment and rehab and got paid every day they were gone? Doesn't exist. They get fired immediately. I didn't get fired. I still had a job. Not only that, I'm teaching medical students and nursing students. And I remember sitting there that day and thought, you know, if I can get through this, I think I know what I want to do for the rest of my life. I wanted to teach people how to properly prescribe controlled substances. I wanted to teach people about addiction, and I wanted to teach people that recovery is possible. And that's how I wound up in front of you here today, because I've done that. In 2015, I took a job with the state of Tennessee under then Governor Bill Haslam. I was what I guess my unofficial title is I was our state's opioid czar. I'm no longer that. I miss being called a czar very much. But really, I was the ambassador for recovery for the citizens of the state of Tennessee, and I got to learn the entire state, which is how I know the people I know, and just how I know Pastor Young. It's how I know Monty, and it's been a blessing. So I tell you that just to give you a little bit of flavor of what my past is like. We're going to talk about it a little more as we go through, because nobody likes charts and graphs and talks. Don't worry, I don't have a single chart or graph in my whole talk. But I will tell you this, a shameless plug. Has anybody seen the Hulu series Dope Sick? Okay. So I'd encourage you to watch it. It's really good to start with, but it's written by my friend Beth Macy, and the Michael Keaton character in Dope Sick from episode 3 on is me. So you'll see what he does in his own addiction, and all of those things happen. 2 things didn't happen. One is that I did not buy a bus and drive people around. I didn't do that. And second of all, by the grace of God, I haven't relapsed, and the Keaton character in Dope Sick relapses. But it's a really good story to start with. It's the story of Big Pharma's promotion, mainly the Sackler family of the drug OxyContin, and then one doctor's struggle with his own addiction as he tried to help people in rural Appalachia. And so from about episode 3 on, all of that stuff happened in my life. So if you want to see it, it's actually there. So when I got started in this, first thing I learned how to do is I learned how to prescribe. I started talking about prescribing and teaching people how to do that, doctors, nurse practitioners, physicians, assistants, because my guess is some of you in this room are students, and those of you who've been practicing, when you were coming through your training, how much education and training did you get on the proper prescribing of controlled substances for acute and chronic pain? Anybody? Yeah, 0, thank you. That one's honest, right? How much training did you get on the recognition of and referral to different levels of treatment for people with any kind of addictive disease? Unless you did mental health training, your answer is 0. What's the #1 health problem in the United States? COVID not included. I had to change that one. What's the #1 health problem in the United States? Not anywhere close. It's addiction. It's not anywhere close. It's not heart disease. It's not age. You go look at the numbers. All those things will be above addiction, but that's crap. Okay? Start throwing cigarette smoking in there. Start throwing smokeless tobacco in there. And you tell me what the number one addiction, number one health problem in the United States is. It's this. Yet we don't have time to teach it in our schools, which is absolutely mind-blowing to me. So I go into medical schools and I'm talking about this. I'm saying we need addiction in our curriculum. We need to talk to our trainees about proper prescribing of these substances so that they'll know we're still going to have people abuse them, but we got to be able to identify risk factors, and we got to be able to be resources for our patients when they get in trouble. And they say, well, Dr. Loyd, we don't have time for it in the curriculum. It's the number one health problem in the United States. You don't have time for the number one health problem in the United States. I don't know about you all. In your training, we had an hour on maple syrup urine disease. I don't even know what the hell that is. I've never seen it. Maybe there's a bunch of people out there with it, but I have no idea what it is. And the reason that we had an hour on it is because they test on it on the national board exams. So if we want to get addiction medicine into our curriculum, it needs to be on our board exams. Right, because those of you that are coming out of your training and going into practice, what I'm going to talk to you about today is going to be the bane of your existence. You're going to dread it. You're going to have no tools to be able to sit in front of somebody and talk to them in a loving and kind way and help them get the help they need, because you just want to write the script and get them out the door again because somebody else started it months ago and you don't want to have to talk to them. And I'll guarantee the nurse practitioners in this room who are practicing right now, am I telling the truth? I promise you that I am. I'm going to try to teach you a little bit about prescribing as we go through here. So when I first got involved in this and I started in addiction medicine, I kept hearing all these things about pregnant women. Pregnant women are this and they're that. I thought these were the worst people I'd ever heard. They're hurting their babies. They don't care about anything but themselves. They're this and they're that. And these are from the treatment providers. Okay, these are from the people who are actually supposed to be providing treatment for them, talking about them like that. And we're in treatment programs, and I was saying, well, tell me what your all's treatment program does for them. Oh, we don't take them. I said, you don't take them? No, if they're pregnant, well, that's an exclusion from our program. We don't take them. I thought, okay, that's interesting. I said, well, tell me what you do if you get a young lady in, and then in the course of her treatment, you figure out she's pregnant. What's the answer there? Anybody know? Kick them out. So you're going to take a pregnant young lady who's addicted to drugs, and you're going to kick her out. And I couldn't accept that as an answer. And I absolutely knew nothing about the treatment of pregnancy. Everything I'm going to teach you guys today, guys, I am self-taught completely. Books, open them up, seeing patients. That's it. I didn't get to go to a training program. I'm jealous. But I couldn't believe that that's what we did. So I'm going to tell you about my first pregnant girl, my very first one. I'll never forget her. I was working in the Tri-Cities. It was around 2011. Heath was a junior in high school. It was in November. I don't know if any of y'all, in Upper East Tennessee, in November, it's cold. We live in the mountains. Okay, and this little girl came in and she had on a spaghetti strap top. It's cold outside. She didn't have a coat on. And I saw these little circles all across her arms, down to about that big. Cigarette butt, right? And so she's just a little bit older than Heath. Heath's a junior in high school. This is her second child. And I'm sitting there taking her history. She's shooting heroin. She's 8 weeks pregnant, something like that. And I took her trauma history. And so when she was a little girl, her daddy sexually abused her. And her mom was in the house, and her mom and dad were both users. Both of them used drugs, and her dad was sexually abusing her. And so when she was 7 years old, she asked for a Yorkie puppy for her birthday. And her reasoning was that the puppy, Yorkies bark at everything, and she felt like if she slept with the Yorkie puppy, that when daddy came in the room at night, it would bark and it would wake mom up and it would keep dad off of her. That's pretty damn good insight for a 7-year-old. And I'm sitting here listening to this going, is this real? And I'm watching her face, and there was no doubt it was real. And so when she was 10, her mom got arrested. So guess who got custody, right? So he raped her every night until she was 13 years old, and she ran away from home. And guys, that's the day I stopped throwing rocks. The kid never had a chance. I'm not condoning anything, blessing wherever you are. I'm not enabling anything here. I mean, hell, that ain't right. You never had a chance. And guys, it changed everything for me in the treatment of these women, because I started to understand that the majority of them have been physically, sexually, and emotionally abused. Until we address the physical and sexual and emotional abuse, we're not going to get anywhere long term. And I would argue that treatment of a baby for neonatal withdrawal syndrome starts with treatment of mommy, right? We got to change the environment that the kids grow up in. Like the environment was changed for Heath. Heath never saw any of that, right? The environment was changed because I got help. So she went all the way through her pregnancy. She gave birth to a child that did not have neonatal abstinence syndrome. However, I'll argue I hate that term because all these children are drug exposed in one way or the other. So I think we need to relook at that, but that's for another day. And then about 3 months after that, I lost her. I don't know where she went. I have no clue. I do know that she lost her baby. Was it still worth it to treat her? It was. It was worth it to treat her because we may get another shot at it one of these days. And that's what I want you all to understand as we go through my talk today. Addiction is not a moral failure. Addiction is actually a disorder of the brain. Really, it's hijacking what the brain is designed to do, which is predict the future. That's what our brains do. And it's hijacked by something, in this case, a chemical. For no extra charge today, when we get to this point in my talk, I'm going to teach those of you with teenagers why they're stupid. They're not. They make bad decisions. But I'm going to show you the reason for that. And I think whenever you start to understand a little bit about the brain and you start understanding it in a way that relates to behavior, then it becomes easier to try to take care of folks with addictive disease. At least it did for me. So I'm going to throw Brooke's story in here because I want to get your attention, okay? I treated probably now more than 500 women all the way through their pregnancy to live births. I don't think we've had anybody stillbirth. We had one lost her child to SIDS about a year in, but other than that, I don't think we had any deaths that I can remember. So when I left the state, I could go to work basically anywhere I wanted to, but there was one place in Murfreesboro, Tennessee, that was going to allow me to start an inpatient treatment program for pregnant women. And so that's where I went. It was called Journey Pure. And so I went there, and not long after I got there, we got a phone call from this family in southern Ohio, a mom and her daughter. The daughter's name was Brooke, and Brooke's mom has given me permission to use her name and to tell the story. I've got all the signed paperwork if there's any lawyers here. She gave me permission to use this story. So Brooke is the toughest patient that I've ever had. She was a certified welder. I knew Brooke 2 weeks before she called me anything other than MFer. And she wasn't using the initials. I would walk in the morning, hey Brooke, how you doing? What do you want, MFer? And I was like, well, that's an interesting way to get my day started. But I'm tough. And I knew where Brooke was in her life. So Brooke's living in southern Ohio. She's got, like I said, she's a certified welder. She's also injecting heroin and fentanyl. And she finds out she's pregnant. She's 8 weeks pregnant. She tells her mom, Angie, they can't find anybody that'll take her. They get on the computer, Google who will take pregnant women who are addicted to IV heroin, and my name pops up. They call me. I said, bring her. Now, the good thing about treating pregnant women is you can scare insurance companies with them. They don't know what to do with them. So I kept Brooke for a long time. After 2 weeks, she started calling me Steve and not MFer, which was that was a red letter day kind of. But Brooke got better and better, and she changed from this person with pick marks all over her face because she also used methamphetamine into this beautiful young lady that I knew was in there. And she really blossomed, and I usually have pictures that I lead off with her. I just didn't bring them today. And so her and Angie actually sent me a picture from the delivery chamber when Ava was born, and she looked so good. Ava was the most important thing in Brooke's life, but Brooke was in Tennessee. I had Medicaid for her, so she didn't have to pay anything. She could come and see me. She could get her medication. She was on 1 Subutex a day. She did really, really well, but she wanted to go back to Ohio. And that's where her family was, and I didn't like that at all because there was one thing in Ohio that I really did not want any part of. Does anybody know what that is? It's something called a baby daddy. The first time I heard that term, I didn't know what it was, but the kids had taught me about Urban Dictionary on my phone, so I looked it up. I know what a baby daddy is. So the baby daddy is actually back in Ohio, and I hate that. That's the worst phone call I get. Hey, Dr. Loyd, my old man just got out. I hate those phone calls, because I know what we're getting ready to face. So she goes back to Ohio. She's got a felony on her record because she had too much in her possession. They got her for intent to resell. So she's got a felony on her record, and she can't get a job getting paid what she should as a certified welder. So she's working in convenience marts, and the doctor she's seeing is charging her $125, $150 a week cash just to write her a medication, not doing anything else for her underlying addiction. And so she's struggling big time. She starts to have some slips. Luckily, she's got Angie there to take care of. Did I do something wrong?
No, I thought you were
Okay. No, I hadn't even started yet. So luckily she's got her mom Angie to help her with Ava. And then she gets put in jail. And while she was in jail, they stopped all of her medication, including her underlying mental health medication. She was on 2. She has bipolar disorder and depression, so they stopped both of those. They stopped her Subutex, didn't give that to her, kept her in there for about a month, enough to detox her, and then turned her loose. And on December 13th, 2020, I looked down early in the morning and my phone was ringing, and it was Angie, who is her mom, and I knew that wasn't good. And I answered the phone, and she said, "Steve, I went in to wake Brooke up this morning, and she didn't wake up. She died of acute intoxication of heroin and fentanyl." All right. Ava's never going to know her mom. Guys, this is a preventable death. This is a system death. This death doesn't have to happen. Most of the deaths in the state of Tennessee around this issue don't have to happen. They're system issues. And a lot of times the system issues are between our own ears because the bias we put on what we think is best for somebody else. Pure and simple. I'm sorry, guys. It's just what I see. I hear this, "Oh, you've got to show them tough love, 3 strikes and you're out, you've got to hurt enough." None of that shit ever works. I've never seen it work a single time, maybe once, maybe. That's not what I see work. So I want you to, what you think you know about addiction right now, I want you to put off to the side for the next hour and listen to what I have to say, right? And you pick it back up later. But there's 3 things you have to do to work for us. 1, you got to love people unconditionally. 2, you got to demonstrate mercy. And 3, you got to forgive people habitually. How many times does it take? I don't know. People ask me, how many chances you get? I don't know. How many they need? How many times would I go in the crack house to get Heath? And then somebody tell me that's enabling. I don't care. He ain't dead. I can't work with dead people, folks. Can't do it. And we're watching kids die in our state right now at a rate that we've never seen before. And they're dying of heroin and fentanyl overdoses. And the fentanyl kills them so quick, they don't have time to pull the needle out of their arm. The needle's still in their arm when they die. They're kids. They're y'all's age. Some of y'all look like my kids age-wise. Right? These are kids. We've got to change our mindset. Now, here's the sad part, is Brooke's story doesn't end with Brooke. Why? Because Ava ain't got a mama. Ava's being raised by her grandparents. So Angie sent me a picture the other night. Ava's potty training. She was standing beside this little plastic potty in her bathroom, and she was smiling. She had done a job, right? She's never going to know her mom because it doesn't stop there. How many grandparents in the state of Tennessee and all across the South, all across the country are raising their grandkids because of this? I'm asking us to change our mindset a little bit and maybe take a little bit different approach. So with that said, here's my disclaimer slide. I'm not going to read all that. The short answer is that nobody pays me outside of the people I work for. I don't take money from pharmaceutical industries. I don't have any outside disclosures, because when you do that, then people start telling you what you got to say. I will tell you that I'm proudest of the last line on here. I am an avid Tennessee Vol fan, which is very, very difficult. But I mean, everybody's always an Alabama fan. Where were y'all in the 90s? I didn't see a damn one of you. All right. My son Heath, I named after Heath Schuler, the quarterback at Tennessee in 1994. Heath was born in 94, so I named him Heath, which seemed logical. My daughter was born in 1997. Does anybody know the quarterback at Tennessee in 97? It's easy. It was Peyton Manning, right? And Peyton would be a great girl's name. So I told Karen, my wife, hey, let's name her Peyton. Karen said, no, that'll make us trash. And she wouldn't let me do it. So I have a Haley instead of a Karen. And I've now been married to Karen. That's wrong, actually. I've been married to Karen for 31 years. So I love quotes. One of my favorite philosophers is actually Mike Tyson. I hope I have a Tyson quote in here. But when I started talking to people about addiction and started trying to educate them a little bit on what addiction is, you get some unbelievable reactions sometimes, because there's a lot of people out there that think we just need to throw them in jail, lock them up, take away their kids, put them over here until they change their behavior. And I don't find that ever working. And so I try to remember this quote by Scott Stratton. He said, don't try to win over the haters. I'm not the jackass whisperer. So I'm not the jackass whisperer, and I've got to stop thinking like that, because that's me slipping into that same mentality. So I told you I'm from Northeast Tennessee. Northeast Tennessee's got a reputation in the state of being just a little bit behind the times, and I can tell you that when I worked in Nashville and still actually live and work in Nashville, Northeast Tennessee is definitely different than the rest of the state. There are no question about that. We still have some people up there that think we're still holding on to Richmond, but if you look at addiction up there, right? It is by far the biggest problem that we face. So there was a clinic that came to town, or wanted to come to town. It was a cooperation between our largest health system, Ballad Health, and our largest university, which is East Tennessee State. And they're going to treat people with opioid use disorder in a nonprofit, in an educational setting. And one of the drugs they're going to use is methadone. And they're going to put it in a little community called Gray, Tennessee. Gray, Tennessee is where I grew up. And so they're going to put the clinic there. And so people came out and protested. And they have these signs, not among our schools. I went up to answer questions. They were scared of the clinic being there because it was so close to a school. One of the commissioners raised his hand and says, I'm worried about bringing drug addicts into Gray. They're here. I promise you. And from the look of some of the noses up there, some of you all have been drinking too much, just so you know. Right? They're already there. They're in your communities already. I grew up here. I'm here. They're already there. The problem that bugged me the most was right here. Those are 3 kids about 10 years old. They got no idea what methadone is, and they got no idea what's on those signs. Now, the law of averages up there tells me that one of these 3, by the numbers, will have this problem at some point in her life. What's her mindset when she has that problem with this in the background? You guys, we've got to stop spreading their hate. Got to stop doing stuff like this. And I was vocally critical of them then, and I'll be vocally critical of them now. Okay? When I was up there was a lady sitting about where you were, I'm sorry, and I was answering questions. There was about 400 people at the fairgrounds, and they were peppering me with these questions about treatment of people with addiction, and she was mean and nasty, and she kept eyeballing me the whole time and taking pictures of me, and I'm standing up in front of everybody, and she says, how many chances does somebody get? And I was looking at her, gosh, I don't know. And she kept pressuring me. While I was looking around, I saw 4 church steeples from where I was standing. And I thought, heck, I went to Sunday school. I gave her the Jesus answer. What's the Jesus answer? Right? Not 7, not 70, but 70 times 7. Jesus' point wasn't 490. Jesus' point many times as it takes. That was the point. And so that's the mindset of the community. Now, the clinic has been open now for about 4 years. It's been a rousing success. They haven't drug a bunch of drug addicts into Gray, right? No school kids have gotten eaten, far as I know, right? And there's been some people that have gotten help. And regardless of what you think about methadone, there are people that need methadone out there, I promise you. And it has about a 70% mortality benefit. What does that mean? That means that 70% of the people who would have died otherwise won't. Name me another drug that has a 70% mortality benefit. If I kick out insulin, I'll save you some time. You can't. It doesn't exist. Right? And it's part of a comprehensive treatment program, right? It saves lives, and we have to keep our minds open to that because we're not dealing with alcohol, okay? The number 1 problem that people have in the United States with substances is alcohol. Why? Because it's widely available, socially acceptable, okay? That's why. If I start drinking today and I drink really, really hard, and I don't have anything else wrong with me, and I don't die in a car wreck, it's going to take 20 years to kill me. If I relapse on heroin, I can be dead this afternoon. And guys, that's what we're dealing with. So what I'm here to advocate for is harm reduction. I'm here to advocate for keeping people alive, hold them in the recovery process until we can get them long-term recovery. That's what I'm advocating for. That's what I tried to advocate for with these folks. So a few years ago, I took my family to Europe. Never dreamed I would get to do that. We went to the Louvre. The Louvre has the Mona Lisa, and I didn't know that. And I go in the room, I'm expecting this big, impressive painting. It's about the size of a postage stamp. Very unimpressive. A lot of people taking pictures of it. I was much more impressed with this right outside of where it was. It was the same painter. This is Virgin on the Rocks, but the same painter, and it was Leonardo da Vinci. And I put it up there because da Vinci said we've got to be fearless about changing our mind based on new information. So when we talk about the treatment of the opioid-dependent pregnant patient, there's how we've done it for a long time, and then there's what we know now. And I want to give you both sides of that because this is a unique place because there are people on both sides. If you said, we need to treat this with medication, the abstinence-based people jump all over you. And if you said, we need to treat this with abstinence, then the medication people jump all over you. Nobody raises their hand and says, what's best for a pregnant patient? That's where we got to start, right? That's got to be the whole focus, not what I think is best, not what you think is best. What's the best route for the patient standing in front of me to have a healthy baby and enter into recovery? That's the path that we need to choose, not the one that I think is best for you. This is my point, Blessing, right? This is my point from a second ago. All right, so first thing we got to do is we got to shape out dependence from addiction. Okay, hang on a second. That's going to bug me. All right, so you got to shape out dependence from addiction. Okay, dependence is easy. Dependence is when I stop the drug or whatever it is, I get sick. That's dependence. It is not addiction, and not every drug causes dependence. Okay, methamphetamine does not cause dependence. People shoot methamphetamine for years, stop it, not get dope sick. Okay. People get addicted to methamphetamine. I'm going to explain the difference here in a second. Common things that people become physiologic dependent on: opioids, benzos, alcohol. When I say benzos, Xanax, Valium, Librium, Klonopin, right? Those drugs, they develop a physiologic dependence. That means I've taken it certain period of time, I abruptly stop it, I go through what's called a predictable physiologic withdrawal syndrome, i.e. I get dope sick. Okay? Hadn't got anything to do with addiction. That is dependence. All right, what is addiction? And this is the easiest one. I've got some mental health providers in here. I know it. You're getting ready to get mad at me, so we'll talk about it afterwards, okay? When we're evaluating people with addiction or suspected addiction, we look for this long list of questions, right? We've got the CAGE, the Audit C, the mini Minnesota, whatever, you know, this long, and we're trying to determine whether or not somebody has addiction. I don't need any of that. I need to know, does my patient have continued use despite consequences? If I can find my patient's got continued use despite consequences, then more than likely I'm dealing with an addiction issue, right? It doesn't matter it doesn't matter if they get dope sick or not. Dope sick's different. Can they be addicted and dependent at the same time? Yes. So let's take Megan here again. Megan has her gallbladder out. I give her Percocet for 14 days. She needs it for 2, but I give her 14. At the end of her 14 days, she stops taking it. Guess what? She's going to get dope sick. She's going to go through a predictable physiologic withdrawal syndrome. That's probably going to be mild, and she may not even know what it is. She'll get a little sweaty, maybe upset stomach, maybe have some trouble with her bowels. It's going to get better in a few days. Does that mean Megan is addicted? No, she's dependent. And the dependence, the dope sickness process, will last directly proportional to the half-life of the drug. Oxycodone has a short half-life, so it's going to peak at about a day, day and a half, 2 days, and it's pretty much going to be gone in 5 to 7 days. Okay, and most people get through that. That is dependence, and I can do that to anybody. Pope, Elvis, don't matter. Okay, that is dependence. It is not addiction. Addiction is the continued use despite consequences. The best one I can give you on this is I evaluate professionals like doctors, nurses, lawyers, all that. So I had a lawyer several years ago that came in, and he came in for evaluation for possible alcohol use disorder. And he sat down in front of me, and here's the weird thing about talking to me. They all know why they're there. Right, I'm not a secret, right? You're not coming to see me as a job application. I'm there to evaluate you for a substance use disorder. So the first thing they want to do is what? Tell me all the things that they're not doing. I never even get to introduce I'm doctor. Nope, none of that. Dr. Loyd, this is all a mistake. I don't know why I'm here. I don't drink before 5 o'clock. I only drink beer. I don't drink wine or liquor. I only drink wine, not beer or liquor. I've never had an issue in my job, which is interesting because you're in front of me, but that's okay. I'm good with that. And so I'm listening to all this stuff, and I'm shaking my head, and then he leans back and he crosses his leg like this. He's got an ankle monitor on. I thought, well, that's interesting. I said, what about the jewelry? And he says, well, I got a DUI. I thought, okay. Your first one? No, my 6th. What was my next question? Now, hold on. An evaluation is $4,500 cash for 3 days. What was my next question? Why are you here for an evaluation? What happened after the first DUI? Number 1, he spent 48 hours in jail in every state in the United States. Number 2, it cost him 10 grand for an attorney. And I don't know how y'all do things in West Tennessee. In East Tennessee, we take your picture and we put it in the busted paper and we sell it at the mini mart to shame your ass, okay? So he had all of those consequences, yet he had another DUI. Guys, the second DUI is no accident. And I looked at him and I said, why are you here? Why are you getting an evaluation? And he put his foot down on the floor and he said, that's a good question. And we walked straight up the hill. He's in recovery today. Now that one ended good, okay? But that's all you need. That's all you need. Now, can drugs cause dependence and not addiction? Yes, I just gave you the example with Megan. Can drugs cause addiction and not dependence? Yes, methamphetamine. People who stop using methamphetamine abruptly do not get dope sick, yet do they continue to use after consequences? Yes. Okay, so let's keep those two things in mind. They're not the same thing, and they matter. Now, addiction. The hallmark of addiction is cravings. Okay, and everybody in the room knows what cravings is. It's the same. I saw all y'all relapse back there about half an hour ago, right? Everybody in the room did it, right? Same cravings we're talking about for food when we're hungry, water when we're thirsty, is the same thing I'm talking about with the substance. But here's the thing to remember about cravings. Number one, they happen as little as 33 milliseconds. How long is that? It's the time it takes you to blink your eye. It's unconscious. How do you defend yourself against something you're unconscious of? Tough, right? It's part of the problem. As Blessing was telling you earlier, it's part of the problems of cravings. Happen within 33 milliseconds. Second thing, they're lifelong. I've been in recovery coming up on 18 years, believe it or not. I still have cravings every now and then. It will happen. I just don't use. I've got other things that I do. I've got other support systems that I rely on to help me with that. And the last thing about cravings is this one. They're 10 times stronger than your cravings are for food when you're hungry and water when you're thirsty. So the next time you look at somebody who's using, addicted to opioids, and you look at them and say, I just want you to stop and put it down. I want you to think for a second. I want you to stop eating. And I don't mean today. I mean I want you to stop eating. How easy is that? It's likely not going to happen. When people find out that I treat pregnant women, they always tell me the same thing. Steve, these pregnant women, they just need to quit. They need to put it down. They're hurting their babies. They're hurting everybody else. And I'm looking at them like, I swear to God, I thought of that. It was like the first thing I thought of. It doesn't happen. It doesn't happen because of the phenomenon of cravings. So you can get through the detox process. This is what we're talking about. You can bring somebody in for detox, right? Standalone detox, the traditional thing we think about. Oh, you got a heroin problem, Megan. Come in here. We're going to detox you for 5 days, and we're going to send you back out into the world. Now you're not going to be dope sick, so you're going to be fine. What are her chances of making it long term if I do that? Damn near zero. Standalone detox is the most ineffective thing that we do for treatment if it's not followed by anything else, and I can prove it. It's a waste of our time and our money, although you can make the argument that 5 days off drugs for Megan is a good thing, and I won't argue with that. But it's absolutely a waste of our time and money because we haven't addressed any of the underlying drivers of addiction, and we've given Megan no tools to handle cravings going forward because every one of you all relapsed, like I said, about 30 minutes ago. And here's what happened. You came in here, if you skipped breakfast this morning and you got here, right, and you're already a little bit hungry, you get that feeling in your stomach, a little bit of empty feeling in your stomach. Your blood sugar drops. You get a little bit sweaty. You look at the clock. It's nearly noon. Look at all those cues that's telling you what? It's time to eat, right? You remember the last time that you had this bad feeling. You remember how you felt, and you remember what cured it. It's called euphoric recall. So you remember, last time I had this feeling, I ate, I feel better. Okay? And you're designed that way. You're designed that way to live to be reproductive age because that's how you live to be reproductive age. And you're designed to have sex so that we can procreate, and our species will go forward in time. This is all a brain function. We're going to talk about it here in a second. All of you all just did it just a little while ago. So when you came in here, you had cravings for food. Now, the cravings for your food went up dramatically when they told you there were food over there. And if they wanted to make it even worse, they could have heated it up and blew the smell at you. Okay? So all of those things are cues to tell you to go over there and eat to satisfy this pang that you have inside of you that's going to allow you to live to be reproductive age, have sex, procreate, and our species go forward in time. That's how our brains are designed. All of you all relapsed. All of these cues are telling you that. Same thing happens in addiction. Same thing happens in addiction. The part of our brain that's responsible for our species going forward in time is also responsible for our will and our desire to live. It's called the limbic system. And we're not going to call it the limbic system or any of those names in there. We're going to call it go. So I'm going to talk about go and stop here in just a minute. So the part of our brain that's responsible for food, water, sex, procreation, species going forward in time, and our desire and will to live is the part of the brain that's hijacked by the drug. Right? So if the object of your brain, that part of your brain, is your desire and will to live, think about what you would do to save your own life here right now. What would you do to save your own life as we're sitting in this room right now? If I got rid of all the food and water in here, which is hard to do around a bunch of nurses, but if I did, if I managed to do that, right, how long could you sit here and just start looking at each other? right? Day after day after day, no food, no water. We're going to do a few things, right? Number one, we're going to drink each other's urine. Guarantee it's going to happen. Number two, we're going to eyeball each other to see who's the weakest, because that's who we're going to eat first. That's how strong your desire and your will to live is. And guys, that's the part that is hijacked by the chemical. It's all brain stuff, right? So when you read in the newspaper, woman across the street in motel room, kid in car, I don't have to read any further. I know what's going on. Know what's going on, okay? And I'm not saying it's okay. I'm telling you, I understand what's going on. I get it. Because I would tell you that when I was using, the most important thing to me was Heath, Haley, my family. It wasn't. I had to have this thing out here or I was not okay. It was not okay. That is the power of addiction. I wanted it 10 times more than you all wanted food when you're hungry and water when you're thirsty just a few minutes ago. And that's the deal with the go part of our brain. So the two areas of the brain I want to focus on. One, buried deep within here. Sorry, something would do me any good. All right, buried deep within here. Sorry, get a little bit smaller. So the limbic system, made up of a bunch of different things. We're going to call it go. And then the other part of our brain I want to talk about right here, the frontal lobe of our brain, we're going to call it stop. So stop and go. So I already told you the two big functions of the go part of our brain are one, desire and will to live, two, procreation, species going forward in time. So everybody, I've already told you how all that works. So whenever you have those cravings, they get to a certain point, the cravings are overwhelming, you know how to relieve it, you've got readily available food, it's right over there. You bring it back to your table, you take a few bites of it. In your brain, in the reward system, the go part of your brain makes its own heroin, it makes its own morphine, it makes its own oxycodone, it makes its own hydrocodone. They're called endorphins and enkephalins. Endorphins and enkephalins are released, it leads to a downstream release of dopamine, and that's what everybody in the room right now is high on. All of y'all are fat, happy, and satisfied on dopamine, right? You just ate. That's why nobody wants to be the after lunch speaker. They just don't know why, right? Because everybody is down because of the dopamine. It's okay, right? Because if every time you ate or drink, you threw your toenails up, you would eventually stop eating and drinking. You wouldn't live to be a reproductive age. It wouldn't matter if you had sex, and our species would die. Okay, that's the way this works. Okay, so the dopamine's taken back up into the nerve ending, waiting on something else to come along and make it release, be it food, but other things cause dopamine release. Spending time in relationship with friends, family, significant other, watching your kids in the school play sports, whatever it is. All those things cause dopamine release and make us feel good, right? That's how it works. So everybody agrees food, water, and sex are good things, right? Everybody on board? Can you think of an instance where food, water, sex may not be a good thing? Okay, I'm not stupid enough to go down the sex route, so let's talk about food, all right? So up until about 6 years ago, I weighed about 250. I tried everything in the world to lose weight. I ate all carbs, no carbs, all meat, no meat. I was a vegetarian one afternoon for about an hour. Tried everything, all right? So what I finally decided was this. I'm going to watch what I eat and exercise. I'm going to do that every day, and I did. I did it every day, and I still do it now, and I'm right around 200 right now. So I've been able to keep the weight off by doing that. I work out at a little gym called Orange Theory, which I love. Matter of fact, at the end of the day today, there's one in Germantown, and I'll be there in the 7 o'clock class tonight. So I get up at 6:15 in the morning where I live in Mount Juliet. I work out for an hour. I burn 800 calories in an hour. It's a pretty good workout. On the way home, I pass a Krispy Kreme donut on my left. I love Krispy Kreme donuts. Okay, I told Karen, when I die, pull the ET tube over, stuff the donut down, and then pull the ET tube out, by the way. Stuff the donut down. I love Krispy Kreme donut. So when I drive by that Krispy Kreme donut, what's the reward system of my brain telling me? Pull in there, for God's sake. You love Krispy Kreme. You remember the last time you had them. I've got a visual right now of that thing sitting there with the sugar dripping off of it. That's what the reward system of my brain's telling me. Food, water, sex, good thing, go have it, right? Now, what's my goal? To lose weight and get in better shape. And that's where this comes in, guys. The frontal lobe of my brain, 3 big responsibilities of the frontal lobe. It does a million things, but these are the 3 biggies. Insight, judgment, and empathy. Frontal lobe of our brain gives us insight, judgment, and empathy. So it is the yin to the yang of the go system. Okay, so our reward system tells us all the pleasures that we can have from whatever it is. Work, life, relationship, doesn't matter. And then our frontal lobe helps us to pick the choice that we have that's going to give us the most amount of pleasure with the least amount of consequences. Our brains are predictors. We do it all day long, every day. You all do it in your jobs all day long, every day. It's how it works. right? So the frontal lobe of my brain says, hang on a second, Steve, hang on. Each one of those Krispy Kreme donuts has 220 calories and 20 grams of fat, and I swear to God, unfortunately, that's true. I looked it up. That's not going to be a huge problem. I'm going to eat 4. 880 calories, 80 grams of fat. What happened to my workout? I should have stayed in bed. Guys, we make decisions like this all day long, every day. Now, Krispy Kreme knows everything that I just told you guys. How do I know that? Number one, they blow the donut smell out in the street. What are they trying to do with the donut smell? They're trying to, for my reward system, to overwhelm the frontal lobe logical part of my brain that's goal-oriented so that I pull in there and I order the Krispy Kreme donuts. That's what they're trying to do, but I'm strong. I've been working at this a while and I'm not going to do it. They have one last line of defense. Everybody in the room knows what it is. What is it? The hot donuts now sign. So they're going to get me with eyes and nose. Next thing I know, I'm talking to them in there, right? And I'm having whole milk, none of the 2% crap. So, guys, this is how we make decisions all day long, every day. What the heck does that have to do with addiction? It's the same thing, right? If you're controlled solely by your reward system and you know that in addiction, whenever you're addicted, that you lose access to the frontal lobe of your brain, essentially you have a lobotomy, you're driven solely by your reward system. So I bring Megan in and I detox her for 10 days and I send her back out in the street and she doesn't have a fully functioning frontal lobe of her brain, so she doesn't have insight, judgment, or empathy, but she's got all the triggers, her phone, right? Dope man's name still on her phone, places that she's been, the significant other at her house that's still using. How long does she last? Day, maybe, right? It has to do with brain stuff, guys, because here's the deal. The stop and go parts of our brain are not neurologically connected until we're 23 years old if we're a woman and 25 years old if we're a man. This is why your teenagers make bad decisions. They're not stupid, right? They don't have a fully functioning frontal lobe of their brain. It's not online. Those of you with teenagers know what I'm telling you is true. Those of you with teenagers that drive, how did you feel the first time they drove down the driveway without you? Why did you feel like that? Because you knew they could die in a car wreck, they could hurt themselves, they could hurt somebody else, and they don't have the insight and judgment to know that. They're driven solely by the reward center of their brain. They get in the car, turn the music on, endorphins and kelphins popping, attaching to dopamine receptors and downstream release, all that good stuff. And for God's sake, if they're interested sexually in the thing next to them, watch out, right? That's what you've got going on. We all know that as parents. If you think of what I'm telling you is a lie, what their insurance rates do when they went to be 23 and 25, they went down. The insurance company knows this too. Okay, so hang in there with your teenagers. They'll be fine if you can get them to live to be 23 and 25. When I do talks in women's jails, and I'm in women's jails a lot more than you would ever think, I tell the women, don't date any dude under 25. That's probably good advice, period. Okay? But you don't date somebody under 25 because he's not going to have a fully developed frontal lobe and not going to have insight, judgment, or empathy. And how can you be in a relationship that somebody doesn't have insight, judgment, or empathy? Okay, so here's the deal. Those connections are arrested in development at time of first use. So Megan is, I'm going to make you older than you are. Megan's 38, okay? And she's in front of me and she's sticking a needle in her arm and I'm talking to her and she's giving me answers to questions and it's making me mad. I do it all the time. Oh God, how in the world could you do what? You know, I do it. First of all, stop doing it. It doesn't help. Okay, I don't do things that don't help. Getting mad at Megan's not going to help her or me. I stop myself, say, Megan, how old were you when you started using? Dr. Loyd, I was 14 and I started using meth with my dad. Belly button wise, I'm dealing with 38-year-old. Brain wise, I'm dealing with a 14-year-old. And I know how to do that. The good news is the frontal lobe comes back online. Oh, skipped all that. So here's a PET scan of the brains. Don't get intimidated by PET scans. I'll make the physics guys in the room nervous with this, but all PET scans do is look and see where radio label sugar goes. That's all they do. So if you had a way to attach a radio label that an X-ray machine could see to a sugar molecule and you stuck it in somebody and lit them up, you could see what cells are functioning. That's basically what's happening. All right, so this top row of brains are brains that are fully functioning. Frontal lobe up here you see is all lit up, right? Normal brains. Second row of brains are brains that have been detoxed off of drugs for 10 days. And the drugs in this case were opioids and methamphetamine. So it's Megan. Megan comes in, I detox her off the heroin for 10 days. All right, Megan, you're good to go. What do you see in Megan's frontal lobe? Nothing. What's her frontal lobe responsible for? Insight, judgment, and empathy. What is functioning in Megan? Guarantee this. Her GO system's functioning, food, water, and sex, otherwise she would die. So I know that's functioning. How long does Megan last? Blessing, this is why standalone detox is terrible. It doesn't work unless there's a referral to a higher level of care and continued treatment. Standalone detox is the equivalent of me breaking my leg, going into the emergency department, the provider fixing my leg in place and sending me out in the community without a cast on. It's the same thing. Standalone detox is ineffective. And it's ineffective for this reason, and it actually kills people. Was it less than 15% of the people that go into a detox unit are referred for a higher level of care when they leave? It's just amazing to me. Now, let's look at this. Bottom row of brains. 100 days of abstinence. Look what's happening in the frontal lobe. Starting to come back, right? Starting to have insight, judgment, and empathy. When I got to go to treatment, I went to a place in Nashville, I've already told you, CPE. I got to stay there for 95 days. So when I walked out, not only did I have a job and a spouse that wasn't using and a house to live in, I also had that. Because it had been 95 days. I was already starting to have insight, judgment, and empathy. Doctors, airline pilots, what are their success rates in treatment for any kind of substance use disorder? At 0 years versus 5 years. You come in on 0 years, at 5 years, what percentage of doctors and airline pilots are clean and abstinent of all drugs at 5 years and back in their job? Anybody know? 78 to 95%. You all don't bat that with strep throat, okay? This is highly treatable. Almost nobody has access to this. Anybody in the room that's familiar with substance use treatment, when's the last time you saw somebody get more than 20 days, 25 days? Almost never. Most of the time they get a few days of detox and back on the street, and then you're surprised when they relapse. And I'm telling you, it's predictable. Okay? Now, why do people relapse? They don't relapse because of withdrawal symptoms. They relapse because of cravings. I've already taught you about cravings. You already know what they are. How long does it take to get from here to here? 2 years. Why do you love medication so much, Steve? Why do you love methadone? Why do you love naltrexone? Why do you love buprenorphine? Because those 3 drugs quell cravings. And if I can quell cravings long enough, now I got a chance to help Megan with the underlying drivers of her addiction. And that's why I love medication. And I hate the way I see it done. That's why I loved having those 3 fellows up here, those of you that came to the pre-conference today, young, bright doctors that are trained, and they're not going to some clinic off in a barn somewhere, which is how we treat addiction and mental health. We'll put them over here where nobody can see them. Right? That's what we do, and we don't want to do that anymore. That's why I get so excited about it. Right? So medication gives my patient a chance to go from here to here. That's why I love it. All right, so we look at mental health treatment in the 1930s. I love this picture. This is from Pelican State Hospital in New York, and this is what we did. When I was little, my grandmother used to say that I needed to be put in a straitjacket. I never knew what that was. I think it's this. Those of you in mental health, I'm pretty sure. But this is what they did. The look on his face in the back, and this guy's just completely given up. And through the years, the stigma that we have associated, or we have placed on people with any kind of mental health issue or substance use issue, this has been what we've done, pretty much. And we don't have the old state hospitals like we used to, or sanitariums, or I forget what they call those other places where somebody went to, quote, dry out, which are just horrible terms. But I'm telling you, we're not much past this. We're not much past it. There are people in this room right now that have a child struggling with substance use disorder, and your best friend is sitting at the table with you and they don't know. Happens all the time because we don't want anybody to know what's going on in the walls of our own house. So this is what mental health treatment looks like. We've gotten some better, but I'm not sure sometimes how much. I compare the crisis we're in with opioids right now, and I can look around the room, and I don't mean this bad, but I see some eyeglasses and I see some gray hair. So you all were around in the 80s, and you remember HIV and AIDS in the 1980s. And you remember the stigma associated with it. Even Dr. Fauci says you can't let your kids swim in a swimming pool with other kids. They might get this, right? At the time, we didn't know. I mean, that's when you get a new virus, there's things you don't know. right? And there's all kinds of stigma associated with HIV disease and AIDS. And it was just, horrible. We had early medications that treated HIV disease. We had AZT really early on. Yet we had almost no access to the medication. And finally, the gay and lesbian community revolted. This group called ACT UP, I didn't agree very much with their tactics, but they got results. They marched on Washington. They said, hey, there are drugs out there that'll save our lives. Stop stigmatizing us. We don't have to die. And guys, that's the same thing we have right now. We have drugs that will save people's lives. I will give you a 70% better chance of living today than you had yesterday, yet we have barriers to treatment because we, quote, don't believe in them, or because, quote, somebody's got to suffer, or so we're trading one drug for another. And these are kids that are dying. We had the same thing happen in the HIV disease and AIDS epidemic. This picture is credited with changing the face of AIDS in the United States. This is David Kirby. He was born and raised in central Ohio. He went to the West Coast. He contracted HIV disease and came home to die. This picture was in Life magazine in 1990. He died not long after this picture was taken. Look at his dad's face. Do you think his dad cared how he got AIDS? Or do you think he cares how he got HIV disease? No. He cares that he's losing his kid. The stigma associated with HIV disease and AIDS, I compare the stigma associated with addiction today. We have kids that are dying unnecessarily because we don't want to name it or we don't want anybody to know. And guys, we've got to get away from that. We have young pregnant women that are out there that are using, that are putting themselves in situations where they can be trafficked or where they can be abused. And we don't have avenues for them to step out and get help, and we got to stop that, right? Because there's a child in there, and I will argue till the day I die that treatment of that child and prevention is going to start with treatment of mommy. That's the way it is, because here's the deal with addiction. Addiction is three things. Right, it's the biopsychosocial model. Usually when I'm doing my normal addiction talk, I got a picture of a slot machine up here. 3 sevens. 3 sevens come down on the pay line. That's when the money's in the bottom. First 7 is genetics, family history. If I asked Megan what, I'm trying to associate what her risk of developing addiction is, I could ask her about her own use. She's probably not going to tell me. Most people don't want to tell you that. The most I've ever had anybody admit to drinking is 2. I don't care how drunk they were, 2, all right? So Megan's not going to tell me that, but she'll tell me about her family. Steve, my dad had alcohol use disorder when he was younger, caused big time problems between me and my mom. Okay, so I know that she has the genetic component. Her first 7 is on the pay line. The second 7 is the psycho part of the biopsychosocial model. What kind of household were we raised in? Right? None of us came out of normal households, but some of us came out of places with physical, sexual, and emotional abuse. Right? So I asked Megan about that. Megan tells me, well, Steve, when my mom and dad got divorced, dad used to hit her, and so they finally got divorced. He got better long term, but mom had, several boyfriends coming in and out of the house. And so, did they ever do anything that you now know is inappropriate? All right, it's not hard. I don't have to get any more in depth than that. Most of the time we uncover that really, really quickly. So Megan's second 7 is now on the pay line with either sexual or emotional abuse. And now all Megan is waiting on is the third 7 on the pay line, which is the social component of the biopsychosocial model. And that is what is widely available and socially acceptable. What's more widely available and socially acceptable than something a doctor writes, or a nurse practitioner writes, or a physician's assistant writes, right? So that's how this all happens. I normally go into that on my other talks, but I love this slide. So when I was looking at treating pregnant women, it dawned on me, what is the picture that changes the face of addiction? I think it's this one. I think it's the drug-dependent babies. Babies are not born addicted. Okay, why? Because babies can't have continued use despite consequences. They're babies. They pee, they poop, they yell. That's it, right? Babies are born dependent. I think people care about babies. And I think if you care about a baby, you got to care about mama. You have to, right? And stop taking them away. First of all, just from a physical standpoint, if you don't give a crap about human beings, we can't afford to do it anymore, right? We can't afford to take kids. We don't have anywhere to put them. We don't have anybody to raise them. Right, so if nothing else, we can't afford it anymore. But I think this is the picture that changes the face of addiction, because I think people fundamentally care about babies. So this is the danger. And guys, the pictures I'm showing you, that baby I don't know, I got that one off the internet. The rest of these pictures are mine. I took this in my office. So I'm up in Northeast Tennessee, and word's gotten out that I'll treat pregnant women. And man, my practice got big in a hurry. At one time, I had more pregnant women than the OBGYNs in town did. And so I went to talk to the OBGYN doctors about this, and I said, hey, are we drug screening our pregnant women? And they're all looking at me like, no, we don't do that. We don't have any of these women that are, Steve, we don't have the women you're talking about. And I'm sitting there laughing. I'm like, oh, really? Okay, wow. Do you drug screen them? No. And I said, why? What's the reason they gave me as to why? Anybody know? We don't know what to do with them if they're positive. That's the system that we're talking about. That can't be our system. Just because we're scared and we don't know what to do with them can't be our system. So this young lady came to me. She was pregnant. She came into my office. She had on a hoodie. She had her hands in the hoodie, and I smelt something funky. And this was a different kind of funky. This was not, bath deodorant funky. This was, there's something rotten somewhere, right? One of them funkies. And so she pulled her hands out of that, sat down. That's the floor of my office. You could see there back when I was there. And I unwrapped her hand, and this is what I found. Sorry, it's not a good picture. The iPhone was not near as advanced as it is now. But that's her thumb. So she was shooting heroin into her anatomical snuff box. If you're looking for injection sites in women, always look under watch brands, okay? Clavicles, breasts, and genitalia, okay? I'm going to hide it between toes, okay? So she's shooting it into her anatomical snuff box. So she gets an abscess there. She's pregnant. She's not going to go to the doctor because at the time, Tennessee had a law that if you were addicted, the way the women read it, didn't matter what the law said. That don't matter. What matters is how people interpret the law. Thought that they would take her baby automatically, and so she wasn't going to go to the doctor and she wasn't going to go to the hospital. So she went up into eastern Kentucky, and there was this dude up there that for money or sex would slice this thing open and drain it for you. No medical training, and basically took a knife out of his kitchen drawer. And she traded him money, pills, or sex for the service. And so he sliced her thing open and drained it. And of course, it was infected. And you all know this. This is going to auto-amputate. When I first saw it, you can see the redness going up. It went halfway up her arm. I thought she would lose her whole arm. Thank God for the $4 Walmart list, because I still couldn't talk her into going to the doctor because she didn't trust the system. So we treated her with over-the-counter, well, not over-the-counter, but $4 Augmentin and clindamycin from Walmart. And we treated her for a long time. This did auto-amputate, but she didn't lose any of the rest of her hand or arm. I thought she would lose both. She didn't lose either. And she actually stayed in recovery. Okay? So this is what I'm talking about. This is what our healthcare system right now is designed for. This still happens today. We still have young women that will not seek prenatal care because of the stigma around addiction and what they think will automatically happen to their babies if they ask for help. And I'm telling you, we have to get rid of that. I'm not telling you there aren't consequences, but I am telling you that we can't have barriers to treatment for that reason. This is the other side of her thumb, and you can see it's just raw meat. I'd really never seen anything like it. I've had a couple of these since then. As a matter of fact, I saw this as recently as last November, this past November that we just came through. So if we look at withdrawal syndromes and how we treat women who are pregnant. So if you look at the withdrawal syndrome and what we call neonatal abstinence syndrome, I think the new term for it, or the thing I see now is neonatal opioid withdrawal syndrome. The length of the withdrawal syndrome is going to be directly proportional to the half-life of the drug. So you look at drugs like heroin, oxycodone, hydrocodone, short half-lives, okay, 4 to 6 hours. So the withdrawal syndrome is going to be peaking at about a day, day and a half, lasting 3 to 5 days. So that's what kind of withdrawal syndrome you're looking at. Longer acting opioids, methadone, really, really long acting drug. It's going to develop in 24 to 36 hours, and it's going to last sometimes for several weeks. I'm probably the only person in this room who's been dope sick or close to it. I see one other possibility, okay? So when you're dope sick, you'll do anything to not be dope sick. If you're going to leave somebody in withdrawals for days or weeks on end, blessing, what do they do when they get dope sick? Yeah, you telling me, when your folks are getting dope sick and getting cravings and the detox, what do? You're damn straight. They leave, right? They leave. So I get doctors in the hospital all the time say, we got this patient in here with endocarditis and we're giving them IV antibiotics and I can't keep them here. They keep leaving. Yes. Why would they not? They're sick. They don't have an active frontal lobe of their brain. They don't have insight, judgment, empathy. You can stand there all day long and tell them they're going to die of a heart attack or some kind of septic embolus. Guess what? They don't care and they don't know. no matter how many times you tell them. What do you have to do? You got to treat the underlying disease process, right? You've got to treat the underlying addiction. And it's easy. It's easy. I need to open up a practice statewide. I'll make billions of dollars doing this. I'll treat them with 8 to 16 milligrams of buprenorphine, and they'll stay there for weeks and get their antibiotics. I promise you that. Whenever you're looking at somebody who's walking out and leaving and it doesn't make sense, there's a reason, guys. And the reason is you haven't treated their underlying addiction issue. I had a young lady who was at a large academic institution, which I will not name, but it was in the eastern half of the state. Okay, and she's in there, she has a heroin addiction, and they're giving her IV antibiotics, and after day 2, guess what? She started getting antsy. She started to become a problem for the nursing staff. How did the hospital respond? They kicked her out. All right, she comes back to my clinic. I treat her there for this awful leg infection the same way I did this one. All right, we can't have a system that's set up to do this. Right, the system has to be, I'm not making excuses, the system has to be to meet people where they are, in this case, treat the underlying addictive disease. Now, I've already told you, obsessive thinking and cravings last for years, pretty much a lifetime. If you look at what the risks are in these women, it's fetal death. Okay, fetal death is what we're trying to prevent. I get people that my women are doing really, really good on medication, right? And then somebody says, well, when are you going to stop the medication? Probably not. The goal is not to prevent neonatal abstinence syndrome. We want to do that, and we'll talk about that in a little bit, but we can actually treat that. What we can't treat is a dead baby or a dead mama. All right, we can't treat either one of those things. Guys, this is about harm reduction. There are no easy answers here, but the answer of just stopping the drug or just not treating him with medication at all because somehow you don't believe in it or, you know, it's against whatever you believe. I don't know. I don't know what kind of rationale you could have for that, but I see it happen all the time. So if we look at effects on pregnancy outcomes, really there's not a whole lot, believe it or not. In the first trimester, codeine has been shown to cause some congenital heart defects. We don't have any known increased risk of birth defects after prenatal exposure to the opioids. Now, I want to encourage you to be careful here a little bit because I know we got some people from the 80s here, and you'll definitely know what I'm talking about here is true. In the late 1980s or early and mid to late 1980s, we had a crack cocaine epidemic in the United States. And we addressed that one by locking people up because it's mainly happened in the inner cities, people of color. And so just say no. Daryl Gates knocking down walls with tanks and people in rooms using crack cocaine. That's how we responded. And they would show these babies in the ICU that were twitching, and they would call them crack babies. And it would tell us about what kind of awful problems we were going to have going forward with these so-called crack babies. Well, that stuff didn't happen. I know it makes logical sense that there's got to be some issues, but I would argue that the environment that the baby goes into is much more important than this. I'm not saying we don't need to try to prevent this. We do. But I'm saying that we have to be careful about just assuming things are going to happen because they certainly didn't happen with those children that were exposed to crack cocaine. We know that heroin can cause fetal growth restriction and some other things, abruptio placentae, some fetal death. But the big issue is really around our women. Okay, if we have women that are untreated, still in those same situations, a lot of them are at risk of having active or acquiring sexually transmitted diseases, becoming victims of violence themselves, being trafficked themselves. And then the legal consequences, loss of custody, criminal proceedings, incarceration. So when I sit down with a pregnant woman, I go over right off the bat these 3 things plus one more. And my plus one more is, what do you think about after the baby is born around voluntary reversible long-acting contraception? I actually start that conversation the very first visit that I see them, and I do it every single time. Never as a pressure, always as an opportunity. Most of the pregnancies in the United States are unintended, UIPs, most of them, right? And in this community, about 95% of them are unintended. So the best way to address neonatal abstinence syndrome is to prevent the pregnancy in the first place. And that's why we start talking about voluntary reversible long-acting contraception. These are the goals for our pregnant women. Number 1, have a live baby. That's goal number 1. We want to prevent you from having sexually transmitted diseases, HIV, Hep C, hepatitis B during your pregnancy. We want to get you out of violent circumstances, and we want to do our best to help you through the legal problems you're in now and to prevent you from having any legal problems going forward. Those are my goals of pregnancy. If it takes medication to do that, I'm good with that. I'm really good with that. So if we look at screening, it should be part of routine obstetric care. And I don't care if you come from Brentwood or the other side of the tracks, don't matter to me. Everywhere. Everywhere. The fastest demographic of heroin users we have in the state of Tennessee are 20 to 25-year-old white suburban women, soccer mommies. Okay? You can't just look at somebody, it affects everybody. It should be done in partnership with the pregnant woman. This is not a gotcha. This is an opportunity for me to sit down with Megan, and Megan's struggling, and me offer Megan some hope. All right, I'm all about hope. All right, non-judgmental approach. Gosh, I see this all the time. People that work in my field, oh, you got to show them tough love. They don't understand anything else, this, that. I don't find that to be true at all. I've never seen it work. Only thing I've seen it do is push people away. And get, well, you're enabling. Well, maybe. I don't even know what that means. But if I can keep them coming back and I can get them run to me rather than away from me, I think we're going to be in a whole lot better shape. I love screening, the 4 Ps and craft. You can look up both of those. They work so much better than what you see on TV. Has anybody seen this show, Intervention? Right? It's horrible. Right? They bring this person in the room, they sneak up on them, they bring them in, and they put them here in the middle of a circle, and then everybody around them in a great big circle reads a letter to them about how miserable they've made everybody's life. And you're surprised with the outcome. They go to treatment. If you follow it, they stay 2 weeks and leave, right, and go back. I don't know anybody who responds to that. I do know about responding. Megan, this is what I see. Right, this is what I see. And I don't want you to have to do that. So much better, right? So much better. Megan, you've made my life hell. It would have been better if you were never born. I mean, come on. So if we look at red flags in our women who are pregnant, seeking prenatal care late in pregnancy is always my biggest one. Right, you've been pregnant for a long time. So I didn't know I was pregnant. You know, okay, pretty obvious, right? Poor adherence to their appointments. Now, there can be other reasons for that. Okay? It can be ride issues, there can be at-home domestic issues, poor weight gain. If you see patients that look intoxicated, they're sedated, nodding off, those type of things are always worried. Track marks, abscesses. Remember, you've got to look everywhere for these things. I was so naive. I thought, oh, everybody injects in their arms or hands. No way. Right? Women particularly. Women will use breasts all the time. Women will use their rectum. They'll use genitalia. They'll be between their toes. They'll always wear closed-toed shoes. You won't see them in sandals. Underneath watch bands. Okay? You have to look in all these places. And you look at me and say, how in the world can you shoot in your genitalia? How's that possible? I've already told you. Because you think if you don't have this thing out here, you're going to die. And it's possible. It's absolute. I'm not condoning it, but I'm telling you it's possible, and I for sure understand it. What time is it?
1:23.
Okay, I'm doing good. I'll tell you about this. So I told you I was using 100 pills a day, right? 100 Vicodin a day. My worst nightmare was going on vacation. If I'm going on vacation, I've got to come up with a lot of pills. So we always vacation when the kids were young at Orange Beach, Alabama. And so we went there with a bunch of our friends. There were about 20 of us total. And at the time, I was addicted to 100 a day. And I'm going to be gone a week. I need 700 pills. That's a lot of pills. And somehow, I got my hands on 700 pills. And I'll tell you all about that another time, all right? But I got my hands on 700 pills. So I get down to the beach. All I got to do is take 100 a day, and I'm going to be okay. I have addiction. I had 700 pills. I thought, well, I'll take a few more today and not as many tomorrow, not planning on tomorrow getting here. Why would I do that? Because I don't have a frontal lobe of my brain. I don't have insight, judgment, or empathy. Okay, I ran out on Thursday, so I took 700 Vicodin from Sunday to Thursday. And so I'm in South Alabama, I'm starting to get dope sick, and I'm thinking, surely to God I can find a pill mill around here. All I got to do is look for a clinic with a bunch of cars in the parking lot, the hoods up, and energy drinks and cigarettes on the ground, I find it, right? So I'll drive around to like 3 family medicine clinics, all 3 of them look legit. So I'm thinking, okay, we'll drive back to where we're staying. If those who've been to Orange Beach, they got a great big wall of condos right on the ocean, and we're staying in one of those. And I pull into a parking lot across the street from that wall of condos at a Rite Aid pharmacy. I'm a professor of medicine in a medical school. I'm living a life I never dreamed I would live. I've got money and cars that I never thought I would have as a kid growing up. I've got 2 kids that are ages 9 and 6. I have a dream life. And I sat in the parking lot of that pharmacy withdrawing from opioids and thought I could write a prescription in here for myself that would probably catch me because my name matching that one. Or I could what? I could rob the pharmacy. I'm a country boy. I don't do it anymore, but I used to carry guns. I had a loaded gun in my lap sitting outside of a pharmacy contemplating strong arm robbing a pharmacy, guys. So when you think what I'm telling you is not true, it is for sure true. Why would it? Do I look like a guy that would do that? Maybe. Oh, I heard a couple of smart alecks from this direction. Maybe so. Maybe so. That's not rational thoughts. I thought I would die without this. When that mom is doing things that are making you crazy, remember, she thinks she'll die without this. Our job is to help her realize she won't die without that. That's what our job is. Right. Other things you want to look forward to worry about addiction anytime you have somebody Hep B or Hep C positive or HIV positive. Right? So if we look at treatment, methadone's been the standard of care since the 1970s. Are babies at risk of neonatal abstinence syndrome from mommies taking methadone? Absolutely they are. Used to make me so mad when I started doing this because the doctors that helped me in addiction medicine were guys that I looked up to, and it turns out that they weren't who I thought they were. But they would used to tell women, if you're on this medication, your babies will not be born addicted. That's what they told them. Told every one of them that. And yet all my buddies who are neonatologists were telling me, Steve, most of the babies we see in our NICU are born to moms taking buprenorphine or methadone. Now there is a disparity there, right? So I went up to the NICU, saw my buddies, I saw the ladies, I saw what they were taking, and it turns out that my buddies in the NICU were right, and all these guys weren't telling their patients the truth. We give all of our women informed consent that this medication that we're going to prescribe for you can cause your baby to have neonatal abstinence syndrome, can cause your baby to be born in withdrawals. It's about a 60% chance, okay? But you're still doing the right thing. You're still doing the right thing. And I'm going to talk about weaning here in just a little bit. But we want to build that. We don't want to run that off, okay? And we want to make sure that our patients know everything. It's our job and our duty to give them informed consent. So the rationale for treatment is to prevent complications of opioid use and narcotic withdrawal. So mommy's withdrawing, baby is withdrawing. So they can aspirate meconium. There can be bad outcomes from baby withdrawing. Our goals, we want to encourage prenatal care. Mommies who get prenatal care have better outcomes than mommies who don't get prenatal care. These are our goals of treatment. And we want to avoid the risk of the drug culture. I've already gave you those other three on the other page. And this is from Samson CSAT in February 9, 2012. Comprehensive opioid-assisted therapy that includes prenatal care reduces the risk of obstetric complications, i.e. if we treat our patients with medications while they're pregnant, we decrease their risk of complications. Pretty pure, pretty simple. Is there a risk of neonatal abstinence syndrome? Absolutely. So methadone, buprenorphine, known as Subutex or Suboxone, does not prevent NAS, regardless of what my buddies in East Tennessee were telling their patients. It is an expected and treatable condition, and of those of you who haven't seen it, it's really, really hard to watch. It is exceptionally hard to watch, and I am not downplaying that at all. But it's better than being dead, and it's better than having a mommy that's not putting a needle in her arm anymore. Hyperactivity of the central and autonomic nervous systems, the things you still see, irritability, have trouble latching on if they're breastfeeding, high-pitched cry, but this also can be confused with a lot of other things, right? And it can be confused with normal babies. And I know I probably got some old NICU nurses in here somewhere I'm getting ready to make mad, but I'm sorry. I want to see a study done of where a baby is evaluated with whoever's evaluating the baby blinded, because I think there's stigma associated with it. And I know about implicit bias, and I know that I myself have implicit bias. There are things that I am biased against that I am unaware of. It's unconscious. And I think the same thing happens whenever we're evaluating babies for going through neonatal abstinence syndrome. And I don't think it's malicious on the part of any healthcare provider, but I do believe in implicit bias. That study will never be done, but I would certainly like to see it. So the timing, methadone, remember, it's all based on half-life. So if the baby is going to withdraw from methadone, symptoms should appear in about 72 hours. So about 3 days after birth, so the baby can be just fine at birth. 3 days later, start to go through withdrawal syndrome, start to have an elevated Finnegan score. Buprenorphine, Suboxone is going to be shorter. By the way, you can use either to treat. Everybody always says Subutex. The reason we use Subutex is because of one case way back in the day in the early 1970s. but you can actually use either. I always use Subutex because I don't get any pushback from the pharmacist, but either is fine. Symptoms will appear in about 12 to 48 hours, usually will resolve in about 7 days. But the thing and the changes I'm seeing there are some of my mommies who are addicted to fentanyl and heroin, those symptoms lasting much longer because heroin and fentanyl are such different animals than prescription pain pills. So I've used an old term up here, opioid replacement therapy. I hate that. I need to change this slide dramatically. It's been a while since I've done this talk. But whenever we're treating people with medications during pregnancy, we want to titrate until our patient is asymptomatic. So Megan, now you're a pregnant lady. All right, so Megan comes into me, she's using heroin. How do I know the right dose for her? I need to get her to the dose where she's not having withdrawal symptoms and she's not having cravings, whatever that dose is. It's as simple as that. I want to prevent her from withdrawing. I want to prevent her from craving and relapse. Okay. If you look at the dosing, people say, well, you need to get on the lowest doses possible. That way you will decrease your chance of your baby being born dependent. There is absolutely no literature to support that. Your risk of having a drug-dependent baby is going to be about 60% regardless if you're on 2 milligrams of buprenorphine or 16 milligrams of buprenorphine. It's just the way it is. So titrating somebody down, particularly if it puts them at risk of relapse and withdrawal syndrome, is not what you want to do. It makes sense. I get it. I feel the same way. But in reality, it doesn't work like that. And then buprenorphine is the only agent that you can use in an office-based setting. If your patient is on methadone, they got to go to the clinic every day, just like every other methadone patient. So what about buprenorphine versus methadone? The advantages of buprenorphine: lower risk of overdose. Really, really hard to overdose on buprenorphine. About the only way you can do it is combine it with alcohol or benzos. And there's evidence of less severe NAS in our babies. Disadvantages: liver function, lack of long-term data, and the dropout rate is higher for babies whose moms are on buprenorphine versus methadone. Okay. If I have my choice in treating my patients, I will always choose buprenorphine if it's right for my patient, because they don't have to go to the clinic every day. I'm not putting them in that circumstance. And I love the fact that the mother study came out and showed that babies treated with buprenorphine had less NAS, they had shorter hospital stays, and they had a shorter duration of treatment for the NAS. That's the reason that I prefer buprenorphine. However, if my patient's injecting more than about a gram and a half of heroin a day, sometimes it's hard for me to control them with buprenorphine, and I have to use methadone, and that's fine as well. Okay? I don't want to stigmatize my patient just because they need to be on methadone. So what about forced tapering during pregnancy? We get this all the time. Well, when are you going to taper them off? Well, it depends, right? It depends on a lot. And so for the longest time, we were told that we could not taper women during pregnancy, because if we did it, we increase their risk of stillbirth and we increase their risk of premature delivery. Neither one of those things turn out to be true, and I'm going to talk about that in just a second. So our goal is to prevent relapse and to prevent and to decrease symptoms. That's it. That's my goal with Megan. Okay. We don't usually taper during pregnancy because of high relapse rates. I taper Megan down. I got her off drugs. Okay,